Today we have Dr. Matt Lambert and Anthony Polizzi. Dr. Matt Lambert is the Chief Medical Officer at Reveleer and is a leader in healthcare innovation, blending clinical expertise with technology, policy, and payment strategies. A board-certified emergency physician for over 20 years, he has spearheaded major health IT initiatives and authored 2 books on healthcare reform. Dr. Lambert currently resides in Washington, D.C. On to our next speaker, Anthony Polizzi. Anthony Polizzi is the Senior Director of Solution Architecture at Reveleer, specializing in HEDIS and MA risk. He leads data acquisition and interoperability strategies, ensuring patient-centric solutions. With experience in genomics, pharmacogenomics, and genetic cancers, Anthony drives innovation and addresses data gaps. His focus on provider sales enhances healthcare quality and reduces administrative burdens. Anthony currently resides in Manhattan, New York. And with that, I'd like to pass the mic over to Anthony.
Thank you very much, Phil. Hello, everybody, and thank you for having Dr. Lambert and myself today. And so I just wanted to set the stage and unite everyone on who Reveleer is. So with over 15 years of experience, we've built a platform to really solve the challenges and the unique, functions that are faced by many people today. So health plans, value-based providers, ACOs, MSOs. And since the industry is continuing to charge toward a more value-based model, we try to stay current with compliance and the latest from CMS. And so our technology really unites and consolidates all patient and provider information to deliver solutions that aid in everything from member management all the way to point of care delivery. So whether you fall within a plan, whether you fall within an ACO, an MSO, or any type of value, cared enablement setting, we probably have a solution for you. And so our success has resulted in actually over 66 million lives on our platform. We proudly serve over 70 customers with a 97% retention rate. And that is continuing to grow as we really stake our place in this market. Thank you, everybody. As we continue on, next slide, please. Today, Dr. Lambert and I will really be focusing in on the problems that probably all of us can agree on this call today. So Dr. Lambert and I have sat on unique sides, and we may have sat in your shoes once or twice. And so our goal is always to really give a consultant view of how we do what we do and what problems we're trying to solve. So as we think of what we're going to learn today, we're going to really think and talk through techniques that really shape diagnosis accuracy, really help you, stratify your populations and understand the risk profile, as well as how do we take the fragmented sources that we deal with every day. So I'm sure most of us can commiserate on over, 20 different types of data feeds coming in 15 different ways, whether it be HL7 on top of XML in RAP CCD, to be able to transform information, but to take that information and hand it off to a provider in a meaningful way so that they're understanding the patient that they're seeing, because it could be the first time they're seeing that patient, or it could be an ongoing, treatment plan or a care pathway. And our goal is to create a very seamless approach that limits abrasion, but augments their knowledge of that patient's risk profile, as well as their quality, functions in a native formation. So we've worked very diligently for many years now in creating native relationships within EMRs to deliver what we have really, quote unquote, curated over time to create the most robust strategy for our providers and our ACO partners. All right, so we're actually going to kick this off with a polling question.
All right, I can hop in here if you'd like, Anthony.
Oh, thank you.
All right, so let me open up the poll so everyone can actually answer here. All right, so First polling question, which of the following best describes your current challenge with prospective risk adjustment in your ACO? Just select one if you could. There's A's, fragmented data across multiple EHRs slash HIEs, lack of standardized risk adjustment workflows, limited provider engagement or adoption, difficulty identifying and validating suspected conditions, inaccurate or incomplete diagnosis capture, or no current challenges. I'll give everybody another minute here or so to answer, and then I'll go ahead and share the results.
And those who select F, I would love to meet with you after and understand your strategy because I want to be with no challenge.
I was just thinking the same thing, Anthony.
All right, I'm going to go ahead and close the poll here now, and then I'll go ahead and share the results with everyone. All right, is everyone able to see the results there?
I know I can.
Okay, great. So it looks like majority of everyone chose option A, fragmented data across multiple EHRs slash HIEs. All right, with that, I'll stop sharing the poll and then I'll let you continue on, Dr. Lambert.
Thanks, Phil. I think that's going to dovetail very nicely into I think the following slide. But so, you know, the CMS a couple years ago stated that by 2030 they wanted to have every Medicare beneficiary in a value-based arrangement. And so we're moving towards that goal. We think we've got 65 million people, Medicare beneficiaries today, 10,000 aging in daily. About half of those are in a Medicare Advantage plan. And so the other half are in traditional Medicare. And so we see that 14.8 million of those are in a VBC arrangement. And so that leaves about another 15 more to be placed in a VBC soon. And what that's really going to do is place a prioritization on scaling this, right? A lot of these traditional ways of chart chases or coding are going to need to be tech enabled or maybe handled completely by the technology moving forward. And it's also moving upstream, right? We can do this now. We know who the patients are. We know we can crawl the scheduling applications and find out when a patient is coming. We can present that information if there is a pre-visit step, and we can present that information to the point of care. And ideally, we'll improve our outcomes with this, and we'll improve our performance in quality, and we'll make sure that we are diagnosing and coding as accurately as possible with these. Phil, next slide, please. So lining up very well with our poll question, we see that 91% of ACOs use multiple EHRs, and 37% have 16 or more. So I'm just going to pause for effect and let everyone kind of focus on the challenges that are created by greater than 1/3 ACOs around the country operating on 16 different electronic health records, and what challenges that create with standardizing anything, let alone the coding accuracy, let alone quality gaps, and let alone trying to scale solutions across different workflows out there amongst your providers. And bridging these gaps is expensive. And we see that it's $3.1 trillion annually to help manage this, to close these data silos or bridge these silos. And all of these gaps lead to misdiagnoses, challenges with care navigation, underreported risk, maybe even preventable hospital stays or acute care stays when it comes to managing ADT feeds. So so we at Reveleer think of ourselves as essentially a data management MSO to help our value-based care partners around the country close these gaps. And it's going to be on the private sector to do this now because we've had the public sector stalled somewhat on a lot of these interoperability challenges. So it's what we see, one of our great value adds to the market is helping bridge these gaps. Phil, next slide, please. And again, the impact that this has on risk adjustment is not cataloging the true disease burden of your patient population and making sure that your bids or your benchmarks are accurate with that. And that results into lost revenue opportunities and also paradoxically, increased audit risk. You know, we see this a lot with with certain cancer codes, recapturing active cancer codes repeatedly, even when the cancer has resolved, to no fault of anyone. It's just kind of the nature of how some of this data is managed. And then, of course, also we see that, we all know the codes that are at higher risk, especially coding an acute MI or acute CVA in the outpatient setting. And so all of this lack of visibility across one silo to another creates challenges when it not only in diagnosis and coding, but also in patient care coordination. We often hear challenges around reporting across this, and few things make you more anxious when you're trying to make data-driven decisions across an entire organization like a large complex ACO, and having your reporting, whether it be for risk capture or quality or admissions, having that in different forms or incomplete at all. And that leaves you at the mercy a lot of times of maybe a payer file. And so we know that a lot of these are going to be incomplete. They're going to be in different formats that you can't get value out of, or going to be delayed 90 or 120 days. So I'm sure many on this webinar today know these impacts better than Anthony and I do, but we just wanted to highlight them here to make sure that we were identifying the problem. So,
and yeah, I believe Dr. Lambert, I just want to underscore like the impact of your previous slide. In 1996, I believe, HHS came out and said by the year 2000, we would be in a fully interoperable state. And as I stand before you in 2025, I still have to understand, APIs and webhooks from EMRs that are still emerging. And I think we would be remiss not to really highlight the importance of data centralization, but also data minimalism, really understanding how to synthesize information in a meaningful way that throws out, a robust, meaningful function, but takes all the burden off of, the systems that are trying to cross communicate. And we'll see, many ACOs on multiple instances of even the same EHR, right? An Epic is going to cross communicate this information. But to get to that information, as they think of, where I'm from. So I'm from the Lehigh Valley of Pennsylvania, and so I do know my local ACO pretty well. But if I were to go into the Philly market, and see Jefferson, right? It's still about 15 clicks for that provider to get the same information onto the same screen from where I was seen at Lehigh Valley. And if we could centralize that in a way that tears down that wall, no pun intended, I think providers would be able to understand patients, in a more holistic method quicker. Because I think, right, Dr. Lambert, you're the first one to say time is of the most importance, right? We might only have 3 minutes with that patient. How do we make the most of that?
Agree, Anthony. And as a former CMIO, I've met plenty of click counters over the years. So I know exactly some of the challenges that that our provider community is facing when it comes to trying to get to the not only accurate data, but data that you can act upon with the patient there in front of you.
Which I think is a great lead into a buzzword that we're all very familiar with. So next slide, right? AI, and how AI does enable and create a unification. So since 2019, we've been honing our skills and sharpening our pencils on leveraging certain types of automation of administrative tasks and administrative burden. So whether it be really honing in to understand how do we programmatically digitally retrieve information, but then what we do with it. And so today you'll be hearing drips and drabs of our AI solution. So AI is core to what Reveleer does. So we have an AI function across all of our solutions. So whether it be quality and HEDIS, through member management, all the way to prospective risk and clinical intelligence. And we call our AI Eve. So if you ever hear us refer to Eve today, Eve is our AI and NLP solution that has many hats depending on what the task is we're trying to solve. And so we're very much of the mindset of creating efficiency where efficiency allows. So which we're really going to hone in today, because I do have Dr. Lambert on the line, around our clinical intelligence solution and our clinical rules engine, which is built off of the back of Eve. And what goes into that to make meaningful use of all of this information, because it is important to understand, different stratification methods, but then layer in that clinical lens to give color to what we're trying to provide to providers. So thinking of clinical rules of taking in unstructured, semi-structured, and structured sources of information and creating something that's tangible. So really honing into the most up-to-date information on a patient, agnostic of where that information comes from. So we might have a BMI on a patient that is, very recent, and layering in comorbidities to create that triangulation around a clinically substantiated inference is very core to what we do. And so we'll talk about some efficiencies we've gained and our customers have gained along the way by using AI in an intelligent way that does create provider adoption and helps you understand the true risk burden of your patients.
Yeah, Anthony, just to add to that, it's, a lot of our clinical intelligence suite has been built on clinical algorithms that the team has been honing now for years. And that aligns to, really sound clinical logic. It also aligns to identifying HCCs that might help with more accurate risk coding, with quality as well. And then the next part that's, as this evolves, the platform is finding all new relationships, just because it's analyzing so much data across so many multiple patients that allows us to even get more predictive when it comes to maybe high cost adverse events. So the foundation is always going to be, as clinically accurate as we can, as complete as we can. It's going to be minimizing false positives and minimizing duplications. That's always going to be the base, or I guess our guiding principle for how we create these. But it's just fascinating to see the platforms come up with new relationships that we didn't realize before or see before. So exciting times ahead for sure.
Thank you, Dr. Lambert. And so I want to dig a little deeper in how this is a reinforced, deployment of what we do and how we do it. So next slide, please. I think it's very important to understand this in a cylindrical format, because it is a effervescent, learning model, right? And what everything starts with in healthcare, as well as, especially value-based healthcare, it's information in. So understanding all of the different types of clinical information, administrative information, and scoring that to its relevancy to what we're trying to do with it. So bringing that information in, and to layer in what Dr. Lambert was saying, a robust, right, language model that was built off of it's on the ICD-10 level, but these clinical rules and heuristics that help inform and continue to learn. And so how we fight bias within that is truly keeping these clinicians in that loop. So we have a team, we call them our clinical intelligence team, right? And they don't say, well, I'm sure they said, but they're functioning in this role to continue to understand the informatics side of what we do and where the future of this information is going. So understanding certain documentation types and patterns is very important. Where to find information, how to utilize metadata and bring in unstructured sources that might be in a JPEG or an image, to layer that in to build confidence and fidelity behind the insight that we're trying to drive. So whether it be a recapture code that is clinically relevant, that we're substantiating to a provider that shows the underlying clinical evidence of why this code hasn't truly resolved on this patient, because we're seeing this trend of this lab, right? To give it more color, because it's important to use time in a very functional way to build trust with providers. And so what that inherently becomes is better outcomes to patients, right? We know this, we see this every day. When we know better, we do better. My mother has always said that to me. So if we're better informed, we are going to create better clinical outcomes for patients. And so What that natively has the function of, because we have real-time feedback from providers like Dr. Lambert, who are eye to eye with a patient, and we can understand certain click reporting, right? So we're tracking engagement. We're tracking how a provider is interacting with underlying clinical information. Are they searching the record that we're putting forth with this lab value? Are they clicking on it? Are they hovering on it? And we're able to take that to better inform the feedback loop. So understanding a trend that is currently getting negative feedback is going to inherently create a flag on our side for our clinical team to go in and refine a rule, or to understand, is this a documentation integrity function? Is this a documentation pattern function, right? Because maybe we're getting documents or charts out of an EMR that we have never seen before. And do we have to hone and understand that format better to be able to create and deduce noise for providers? Or does the rule need to be updated because we're seeing different trends in how the rules are interpreted by providers, especially on the HCC level? And this is agnostic of model. So thinking of patients who are in, Medicaid versus patients who are in an ACA function, or in true Medicare, Medicare Advantage, MSSP, because we've honed this and started it on the ICD-10 level, right, we can map out to whatever risk category or function that you're currently working in. But all this to say is that it continues to learn, right? We're very much in the mindset of reinforced learning, because we have this real-time feedback loop native with our product. And so whether we be natively integrated into that instance of Epic or Athena, or maybe it's a meta EMR that doesn't have the technical advantage to have that bi-directional API relationship, where we can create an iframe of our solution for providers to see that information, we still track as much as possible to the level of granularity to help create that feedback and inform our decisions within data science, as well as our AI team, and then our clinical team as well, to round that out to make sure that everything is compliant, and the information we're putting forth is all clinically relevant. Anything to add there, Dr. Lambert?
Yes, I want to especially double click on step one there on data management. On the provider side, spent all the years I spent there. Sometimes you just know that you can't see, right, or that you don't have insights into your performance or to where you need to improve. And I've just been the years that been on this side of the essentially I consider us a data management organization, or a data MSO, if that resonates a little bit better, because it's to recruit and retain this kind of data management talent, to normalize this data, and then to scale it using AI technology in order to get those insights, is just a really big challenge for a provider organization, ACO organization, a big CIN. So I think that's really where we can contribute a lot to this, to grab these disparate data sources in different formats. Maybe different payers have different formats, so to get that all together in one way, you can get insights out of it. Your better insights drive your better outcomes. And then the feedback loop is just so important, because we're constantly changing or refining or remodeling, whether it be the CMS model, whether it be the HHS model, whether it be the Part D model, or whether it be CDPS model, which is our base Medicaid setting. To get, of course, you're going to get guidance on how these models might change from CMS or from HHS over time, but also just our end users are really help us shape this and improve this. I joke a lot. If I miss something, I get one email. If I put a false positive out there, I get 100 emails. So that's very often our guiding principle is how our end users are interacting with the information we put in front of them.
Yeah, and I think you drove that point home around the data. And I think most of us sit here in an affiliate model, meaning we are truly segmented at our core, and ACOs are trying to unite that. And so it's important to stand behind them with that unified approach of how do we centralize and then create a unified delivery method. And I mean, Dr. Lambert, we're going to drill deeper into each of those three main functions around how do we look at this through a workflow lens. So I believe we have a question on the next slide.
Yes, we have our next polling question. Let me get that up for everyone and I'll read it off. Let's see. All right, so polling question number 2. What stage is your organization at in adopting AI for prospective risk adjustment? Option A, fully implemented. Option B, in pilot or early adoption phase. Option C, planning to implement in the next 6 to 12 months. Option D, no plans to adopt AI. And option E, not sure. I'll give everyone another few moments here to answer, and then I'll go ahead and share the results.
And I think questions like these are important to underscore the level of engagement and adoption across our nation, whether it be, a truly rural ACO in Iowa versus, I like to pick on them, my home ACO of Lehigh Valley. But it's important to understand that we need to meet people where they are. And so Dr. Lambert and I will discuss, different techniques we have to truly augment existing workflows, but also to implement new workflows where we deem fit.
Thank you. Thank you. All right. It looks like close the poll here, and I'm going to go ahead and share the results. Looks like the majority here actually opted for option E, not sure, followed closely by no plans to adopt AI.
Interesting, Phil. I would have bet wrong here. I would have bet that we had a little bit more of a bell curve distribution, but I think not sure, no plans to adopt AI. I think is going to be Anthony, how we're probably going to spend our next couple of years, right? Of helping that part of the curve. All right, thank you, Phil.
Yes, thank you both.
Okay, so it's again, as practicing for over 20 years, I always break it down to the clinical workflow. It helps me make sense of it. Hopefully that that extends to the audience as well. But unifying these clinical insights before the time of the visit is something that has been a relatively new development that we can do with the maturation of scheduling applications and with the APIs to pull that information forward. So to use Epic speak for a moment, we're always crawling cadence. We know who our attributed lives are. And when we see one of those patients who is scheduled for a visit, then that is going to call our information sources and pull it forward. And whether that be directly from the electronic health record itself, problem list, medication list, immunizations, whether that be from clinical notes, within the electronic health record, whether that be within a claims file, that could be in a data lake, a data warehouse, or from, again, to use Epic Speak, Caboodle, pull that information together. And then also looking for the non-structured data that in HIEs and in the CCDA format to help you find information for encounters that are outside your particular instance of an electronic health record. And this is really important also, a big value add when you think of multiple web-based, ambulatory-based electronic health records that are maybe, if you're in that 37% that has 16 or more of these, pulling all of that information together in a meaningful way that has the hierarchy applied to it. Again, that's the CMS model, the HHS model. It could be the Part D model. It could be a Medicaid model. Applying the hierarchy, dedupling it, and pulling that forward in a way that that makes clinical and business sense. We can also pull this forward if you have a CDI or a clinical documentation improvement team or a team of pre-visit reviewers. We can also bring some of that information together to help tech enable them if in their work and in their reviews. And we try to do as much of this as we can with the technology, but maybe for a patient who's got an active cancer code, or for maybe a patient who has multiple outstanding gaps. Or if it's if it's a patient who's in your high utilization group, maybe it makes sense to have a human eyes on those that presented in this format, but it's going to always focus on recaptured diagnoses, right? We need to know our chronic disease burden, and we need to make sure that that is captured annually in each reporting year. Then the next step is if we think we found a net new suspected diagnosis, maybe this is something that has happened outside of your electronic health record. Maybe this is something that's buried very deep in the lab section, and a provider would find it if they had unlimited time, but we all know that they don't have unlimited time. So we'll pull that information forward. Next, quality gaps. We all know that they're always shifting a lot of the regulations here, and this is very often driven by contracting. And maybe what is in the contract isn't widely known across other parts of the organization, especially the provider groups. So far and away, this is going to usually be the cancer screenings for colorectal cancer and breast cancer screening. The diabetes measures are very popular. And then we also see the medication adherence measures for blood pressure medications and for others. Those are far and away the most quality gaps, to find which one of those are open and pull it forward in an actionable manner. And then providing a link to the evidence to see that. So that way, everyone either in that pre-visit review team or on the next slide, as we're going to see at the point of care, everyone has who will be looking at the information has access to the evidence, and that way they can act upon it confidently using their clinical judgment.
And Dr. Lambert, you did discuss one function there around appointments. And so maybe it would be important to explain the different types of appointments and how, AI does aid in understanding appointment type for what is about to be shown.
No, that's a great ad, Anthony. I'm sure that as many of our stakeholders on the webinar today know, to pay extra attention to your annual wellness visit is usually when a lot of organizations use that to prioritize chronic condition capture, quality gap closure, because it's a visit that's more extended in time and not necessarily tied to an acute reason for the visit. So it's a really good time to capture a lot of these insights that are going to help you identify the disease burden correctly, and also maybe think of some new treatment measures for a particular condition in a patient that's not responding. I think the other big one is on a transition of care visit, where we see the priorities might be a little bit different for that as opposed to acute visits. So when we see in the data, we see a recent CPT code for an inpatient admission. We see a recent CPT code for the discharge. We see a recent CPT code for an ED visit. We can target those transition of care visits to make sure that very often the care plan changes after an acute visit, and to make sure that we've got that medication refilled, make sure we're on that new care plan and sticking to those priorities after the visit. Anthony, are those the two that you were leading me to the most? Did I leave one out?
Maybe I was leading the witness, but also to the point, right, of understanding the timing of appointments, whether it be a sick visit, and then using, smart prioritization of information to make the best use of those appointments. So as Dr. Lambert, underscored around an annual wellness visit, likely has a more open aperture to information we would push because we know we have more face time with that patient. Whereas if we know that patient's coming in for, a quick sick visit that is, 10 minutes or less, we can prioritize different functions of information to be pushed to providers to make the best use of their time, knowing that we might be seeing this patient again this year to capture other information.
And Anthony, and also think of timing of the year.
Exactly.
Presenting a influenza quality gap outside of October to March is a really quick way to become unpopular with end users. So that's a good example of not necessarily tying this to a visit, but also to the time of year and to the priorities that you might see during respiratory season as opposed to a different time of the year.
Exactly. And I just think that truly helps encompass that, we were provider built for providers. And they've sat in many of your shoes for quite a bit before coming to the vendor side to help create these solutions that people want to engage with.
Well said. All right, moving on to the point of care step. Thank you, Phil. Spent a significant portion of my career leading providers to new technology. And so this is something that's really a priority for us. And we know that aside maybe from aligning incentives with performance on HCC capture or on quality gap closure, what's going to drive utilization and performance more second to that is going to be getting directly to the point of care. So we've spent a lot of time and developed multiple relationships with the EHR vendors to make sure that we are as integrated as possible. And this looks a little bit different. And I'll just go down in the weeds a little bit on some of this. So Epic, it started out as their app orchard, then it was their app market. Now it's vendor services. Now I think they're calling it Open Epic. But that's less important, that they've really formalized this to a more than any other electronic health record and kind of reinvested in this. They've asked us to participate in what they call their clinical CDS hooks or their clinical decision support hooks. So that means that we're feeding the back of a best practice alert or our practice alert. So we hear BPA or OPA a lot. And so we present this information at the point of care where a provider can act on it following their normal workflow. The Athena Marketplace is the API partnership with Athena. It is probably our second most common installation. And we've got a couple different ways to do that. You see on the right of your screen there, our user interface, where we can integrate with Athena in that particular place where a provider, if this is something that is aligned with my clinical judgment, I hit accept. That diagnosis files as a visit diagnosis directly within the electronic health record. If I hit dismiss, that means this is something that I think is resolved or not aligned with my clinical judgment. You also see the feedback button there at the bottom. The provider can give us feedback with their words or feedback with their actions on this. And then the not evaluated button is a signal, the provider saying, I see this, I want it to stay for me to consider through subsequent visits throughout the year, but I'm not comfortable acting on it today. Maybe I need to order an additional diagnostic test. Maybe I don't have time today. So that is what our user interface can look like in a movable, sizable window within Athena and with other electronic health records. Or if the provider organization is already using the Athena risk tab, then we can direct our insights into Athena natively and make that a point of emphasis for the providers to work there. Similar with the Cerner code program, ECW has an ever-growing FHIR API library that we can work with as well. So the market has made us meet organizations where they are with their technology. And any chance we get, we are going to embed that into the electronic health record in a way that the providers tell us that they want to see it. And so that allows for scalability across networks. It allows for maybe even standardization of your workflow. And that's only going to help with reporting if you have standardized processes across your ACO. When we're going to give you a link to evidence, especially when it's some of that natural language processing derived insights. We can actually take you directly to the document where we found it. And that's really key for those maybe insights that were found outside of your instance. And this is going to help, again, we try to, whenever possible, we try to avoid asking a provider to go outside of their workflow or to go to a portal. We try to get that information as much as we can directly into the electronic health record. Anthony, what did I miss on that?
Not much. But I think it's important to really understand that this is where the rubber meets the road. And this is the most pivotal point of what we do. And so as we take a minute to reflect on, we can push information all day long, but if we don't push it in a meaningful way that fosters engagement, we won't have provider buy-in. And our goal is always to have the provider on our side of this equation. So yet again, I know I'm going to be a bit redundant, but really focusing on data minimalism or the mindset of this is what's relevant, this is why, right? We're not going to send this, this patient has, a glioblastoma because we saw, some medication, but really honing in on the understanding of what tolerances there are around engagement strategies. And one thing we really take into consideration is where these providers are in their value-based care journey, right? We know it's a long and winding road, and we have early adopters who have been doing this since 2005. But we also know we have transitioning providers who are newer to the understanding and the rigor of value-based healthcare, but they believe in the mission, which is very important. And then it's very important to then have them understand, well, here are the gates of entry, or here's what your pivotal piece of this equation is in the value-based care journey. So really fostering a well-rounded view to think of why would we want to, link supporting evidence to something we're finding above and beyond that EMR. Because the provider is going to want to see that impression where there was a calcification on an aorta, but it was found from, a cervical CT, right? Something that maybe they didn't have within their own, care pathway or diagnosis of this patient, but as a byproduct from another provider ordering that, now they're made aware to the acuity of that disease interaction with what's currently going on with that patient.
Yep.
But to also underscore, not every provider is going to take this natively into their EMR. As I stand before you today, I know many providers who are still on paper. And I know we can laugh about that all day, but it's very important to meet providers where they are. So we are a very, very agnostic approach. While we believe that the gold standard is to natively integrate this into their EMR, because then we can aid in the continual process of the documentation and how the documentation then feeds a claim and so on and so forth to get this information out the door to CMS. But we also would be remiss to say, okay, well, not every EMR has a native ability to portray information. And so we've really tried to figure out, and we've hit number 42 EMRs that we're able to have at least a unidirectional relationship with, meaning we can show our insights. We might not have that bidirectional relationship to be able to push information in, but then we can still create awareness when that provider is seeing that patient at that given point in time, and to meet them also within their other risk tools, right? We are in the day and age where we're competing with, native EMR functions. We're competing with other vendors in the space. There's other vendors who can do last mile differently than us. And so while we are very, very proud of our integrity with the clinical information we're able to provide to a provider, we do know that we can augment other vendors or other, delivery methods down the road. And so whether that be a flat file or, gap reporting or different distribution methods, there's flexibility. But first and foremost, right, I mean, Dr. Lambert is correct in saying getting this native into an EMR is very important because, 40% of people are on Epic. We see another 18% on Athena in the ambulatory setting. So really meeting providers where they are is what I'm getting at. And I know I'm droning, but Dr. Lambert.
No, and as we'll go to the next slide, a good example of that was the FQHC workflow, right? They had a huddle workflow, and some of our provider partners asked for a piece of paper to facilitate that meeting, maybe at the beginning of the day and at lunch, and that's been a good way to present that as well. But when we go to the next step, so now we're going to focus on, ideally, and Phil, if we could advance the slide, please. Ideally, we've identified these priorities pre-visit. And if you have a pre-visit review team, they've been able to look at that. If not, many times the platform will present this information moving forward to the point of care. We've got the provider acting on it at the point of care, but we also have an additional step that we can facilitate for that post-visit pre-claim window. If you have the ability to maybe capture a new diagnosis, or most commonly to make sure we've got the robust MEAT measure, evaluate, assess, and treat documentation with that. That's the most common breakpoint in this step. We have the ability to capture that post-visit pre-claim and have the ability to reach back upstream and ask the provider to maybe get a little bit more of a specific diagnosis, or to get a little bit more robust robust documentation. This is going to really help you with your compliance risk. And also, I think a real value add that we hear across the provider organizations is, you know, where you are, you know, whether it be a click report at the point of care or whether it be coder actions here, you can know what your performance is within 3 days or sometimes the next day of the visit. And that really takes you out of that driving from behind that so often happens when you're 90 days waiting on that claim file, 90 days, sometimes maybe even 120 days. And you're still in that window where you can act upon it. So this is another, again, ideally, we've identified the opportunities pre-visit, we've acted on them post-visit, but to use a step here to hit that window before is very often a value add for our other ACO and provider customers around the country.
And through a compliance lens, first and foremost, but it's truly to substantiate, you know, all of the work that the provider has done up until this point, that we're truly getting, you know, the actualization of this as we think of the full span of what we do. And right, this is very important, especially in concurrent payment models. So think of your MSSPs, our ever fading ACO REACH program, where if we can get it right the first time out the door, right, your benchmarks are going to actualize in a more compliant, more up-to-date method. But even as well as your prospective payment models or your alternative payment models that we see in MA or other value-based arrangements like bundling, it just helps with the timing, because we all know that that's the enemy that we're fighting against. Is the time frame of getting this information correct, making sure that we're truly compliant in that, and then getting that truly provided through. Next slide. I just want to kind of ground us and bring us to where we have seen success, right? We have worked with many ACOs. We've worked with many multi-state national risk-bearing entities. And so what we're actually talking through today would be a case study where they have many challenges like you. It's the data fragmentation. How do we unify, you know, a provider in New Jersey with a provider in Ohio and get information back out to the point of care? Also being blind, right? A lot of the time we are blind going into these arrangements because we don't know the true acuity of these populations, because they're aging into this population, right? Think of newly, you know, attributed ACO members who just turned 65, right? We don't have much clinical information on those patients, let alone claims information, because they're not running through a traditional Medicare arrangement, as the example today is. So as we think of what is just a native byproduct of the world we live in, is to truly hone in and understand how can we digitally retrieve information from a multitude of sources. So think of information that you're already currently using, DPC claims, AB2D, all of this information, but make meaningful use of it, but also pull in the clinical side of that. So whether that be us having a native integration into that EMR to source information, tying into your local and national HIEs, pulling that information on your behalf and centralizing it. Dr. Lambert has talked about the harmony that comes with that data repository that is patient-centric, but is also flexible. So pulling all that information is great. So we all know what it takes to get access to EMRs, get information natively, but being able to flip that narrative and get that information so much quicker allows you to inform your providers quicker. So we're able to pull information on those 70,000 lives within 2 weeks, right? That's a pretty great metric. That's probably one of my biggest victories here within that, because as we know, value-based care always starts with data. So getting that information in, but then synthesizing it. So looking at it in a holistic method of understanding what is persistent. So looking at those claims to be able to give us that numerator and denominator, so that when we think of, are we finding net new opportunities that haven't been captured on a patient, right? 62% of this population had undocumented HCCs. And so whether that be through a inference lens or through a lens of true just miscoding and misdocumentation in previous, we were able to serve this information up. And so as we think of that whole population of 70,000 patients, right, we were able to lift, their risk profile by 13%. So making a base assumption that all of them are a 1, right, which is pretty impactful. I know there are certain caps within some of these, programs with reach and global and professional risk, but your MSSP, right, truly getting to the core of, if we can centralize and harmonize information in a way that providers want to interact with it, you're going to get better engagement throughout that year to be able to serve those net new diagnoses that previously they had been, misdiagnosing or under-documenting the true acuity of that population to then affect your benchmarks and your reimbursement cycle in a truly positive way. Anything you want to hit on here, Dr. Lambert?
Well, actually, there's a question in the chat.
Oh.
And yes, and I know we were going to take questions at the end, but I think we're pretty close to at the end. And actually, the question fits pretty well with the case study here. And the question is, do you have metrics that demonstrate the net new diagnosis gaps identified through your post-visit summary workflow? And the short answer to that is yes. We and you'll find we have a pretty robust supporting suite that typically once we're deployed across an ACO or across an MA plan, you'll get have a monthly meeting where we talk about performance across the population, all the way down to individual provider reports. So we can tell you where you're doing well on your capture. You can tell you how we're acting on suspects, and that's the one that really feeds our engine is how well the providers are accepting maybe something that we're presenting net new. And we would do that on a monthly basis with your executive team. We would also give you access to the dashboard to do self-service reporting if you wanted to do that off cycle. So I think you would see that very robust and not only provider action, but pre-visit reviewer action, coder action, and we can give you your performance across your organization all the way down to an individual provider and how they're doing compared to their peers. And we usually, and as I said, we usually share that monthly.
And I think that peer-to-peer is very meaningful in the day and age where we can truly, understand patterns and behaviors. And yet that dovetails very well with where they fall within the engagement process. And all of that creates provider education and allows the ACO to help, target where would we want to, start with our educational patterns and how do we unite, the ever-changing landscape that we function in.
Yeah, well said.
Next slide with 5 minutes to go. Perfect. So to summarize, I think what I do as a solution consultant, solution architect, everything falls within a diagram. So I'd be remiss not to talk through yet another diagram of how we do and what we do, just to summarize what Dr. Lambert truly delineated very nicely today. So again, I know I'm on my horse about this data acquisition, but without it, we can't run the engine. So think of this as the gasoline that's going to power the engine, that's going to move the wheels for the rubber to hit the road at the point of care. So really driving toward understanding 3 main data sources, which would be structured information, so historical claims information, DPC, A22B, all of these different data aggregators or claims-based functions, right? Think of your CCLFs that you're able to get for your certain reach lives or MSSP lives, but then taking that a step further and augmenting it with that PCP, so the provider who's typically at risk in this illustration, right? And getting their information to layer into that claims information to put some color around it. So knowing that this recapture code is truly validated because this patient's still on this certain medication and it was just refilled last week. So helping to build information and then to fully round out that complement with external information. So understanding that patients are transient. Majority of these Medicare members are seeing and seeking care outside of your ACOs. And it's very important for us to track that information down through interoperability. And so we still are marching toward being, an interoperable function within this ever-changing landscape to continue to forge better and more flexible information. And I think TEFCA is doing a good job of that, but I believe we're in the messy middle. But to say that all of that information, now we have, typically on average, if we average that out in pages, that's about 2,000 pages of clinical information per patient. We need to do something with it. And that's where we've talked about our clinical intelligence engine, or EVE, to use AI and NLP to truly sharpen and to hone out clinical insights that are not only relevant, but substantiated with underlying clinical evidence to put forth to the workflows. So whether we're, keeping a human in the loop ahead of that visit in that CDI function, so creating native efficiency, aiding in their review process by only serving them up patients that are complex, that we can't, hop or skip over that CDI step. So because we would want a human or a CDI professional to aid in that process to validate what gets pushed to the point of care, but then to aid in where the rubber is meeting that road, so the tires are going, with that point of care integration, or surfacing this information, whether it be an existing care platform, maybe your ACO does have a certain function or a portal, but maybe we're struggling with getting data in the door, but pushing that data forward, and then aiding in that post-visit review, so we know that it's the right record, right claim going out the door at the right time for the true actualization of all of the work that had been done before that. And with that, I'd like to talk through a few takeaways. I think that, helps round out the time. I know we have 2 minutes. Next slide, please. So, I think Dr. Lambert, I don't want to speak for him, but I think our hope for all of you is to understand the importance of tearing down those data silos and building a unified centralization of data to help understand a patient's risk profile that then can be carried on to drive a better provider engagement with less noise and abrasion. So really thinking like a provider would think, and then how that information then, aids within your shared savings or whatever type of arrangement you look like or you're in current state, and helping, create those adverse, risk compliances that we wouldn't want to happen because of misdocumentation or all of those different functions. So as we think of what we talked about today, really thinking of the provider and how they're at the heart of this, but what we can surround the provider with and give the tools in the tool bag to make better informed decisions is near and dear to Reveleer. Anything to layer in there, Dr. Lambert?
That's a beautiful summary, Anthony. There's nothing I can add.
Thank you.